Okay, so when we do these OSCEs, we want you to remember to be appropriately dressed. So you'll wear scrubs, most likely, your white coat, your name badge like Gladys has on. And you'll be clean, your hair is nicely tucked away, your nails are trimmed. Things like that are an important part of the professionalism aspect of this, and you guys can see what this is. You'll go knock on the door, go inside your room. You always say, hello, my name's Christina Beard, I'm a PA. Dr. Morris asked me to come in and do a physical exam. I'm a PA student is how I would say if I was you guys, because you always identify yourself as a student. Dr. Morris asked me to come in and do a physical exam. So, hi.
Hi.
What's your name?
Gladys.
Okay, and what's your date of birth?
10/23/89.
Okay, so what you do is you confirm your patient's name and then one other sort of identifier, usually date of birth is the way to go. So then I'm going to be doing a physical exam on you because Dr. Morris told me to. You're here for your annual physical exam. Wash your hands, and then you get started. So then after that, that's the first part. That's the introduction section. And then during the whole exam, what we're going to be monitoring you guys for, see if you interact well with your patient. For instance, I'm not using medical words around my patients. I'm not saying, I see that you have some, polydipsia or whatever, and you're talking to your patient like that, and they're going, huh? You would know. But, not an average patient. So what you do there is we're assessing your entire interaction, whether you're making your patient feel comfortable, whether you're being professional or not, and also if you're giving clear instructions to your patient on, I'm going to be doing this, I'm going to be doing that, I need you to lay flat, I need you to do this, so that you're not confusing your patient. So we're working on things like that. Okay, so then we'll ask you to take your vital signs. We'll either give you a vital signs or we'll ask you to take some vital signs, your pulse, blood pressure, respiration, all the stuff that we practiced. You'll perform your general survey. Now, general survey is usually something that's going on in your head, but we can't read your minds, fortunately or unfortunately. And so you will have to say it. I'm assessing my patient's general status. I see that she's not having any difficulty breathing. I see that she's clean, well-nourished, and appears well-dressed. And she's not in any acute distress. So that's what I would say in the testing room if I were a student. And that's your general survey. So then you begin your head exam, your ear exam. We're going to go over your nose exam. Skin is on here as well, but we won't go over that today because we've already done that. And then the lymph nodes, we've got mouth and throat and neck exam over here too. So with the head exam, what you say, because again this is observation, is I'm observing my patient's head. I see that you're symmetrical, there's no evidence of trauma. And I'm going to use my fingers to feel your head.
My hair's a little damp, just so you know.
That's okay. And so what you'll do is you'll give your patient a heads up, clear instructions. So then I'll palpate my patient's head all the way around, and I'm feeling for, and you're saying this as you're doing this, not to your patient, but in the physical exam world, any bumps, tenderness, crepitus, signs of trauma when I'm feeling your head. Okay, so forehead, all around, facial bones. Okay, and I'm feeling my patient's TMJ open and closed. Good, you got some clicking there. Okay. Okay, so that's the entire palpation part. Actually, hold on, pause. Okay, so the whisper test. So, as we said yesterday, I'm going to ask you to place your fingers and occlude your left ear. Dog, paperclip toy.
Paperclip toy.
And I didn't instruct my patient properly. I'm sorry. I'm going to whisper 3 words, and I want you to repeat them after I'm done. So I didn't do that correctly, but you knew because we did it in class. And then I'll do the same thing on the other side. Occlude your right ear.
5, 8, 9.
Okay. So that's your whisper test. Yes.
Okay, question. Will we say it as loud as you're saying it right now, or are you saying it loud to all of us?
Are you saying I whisper loudly? Yeah, however you whisper.
Okay.
I always there's this tech that at the Carolina Eye Place that I work, and he whispers like this, and it gets on my nerves so bad. So hopefully I'm not doing that.
A stage whisper?
Whatever your whisper is, and that's kind of my whisper, so. But yeah, whatever your whisper is. And remember, this is just a gross way to test hearing. So, you know, if they really do have a hearing deficit, they won't hear you at all. You know, so you'll be able to pick up on it.
What about geriatrics?
Yeah, so
They're
people
kinda
who
hard.
already have hearing problems, you're going to kind of know because you're going to be talking to them and they're going to go, what? And you got to talk to them like this. So would I do the whisper test on that person? Nope. Because I already know that person has a gross deficit with their hearing. Now, would I see if it's worse on one side or the other? You could do that, but you can do that with the whisper test.
I was gonna ask, would you wanna ask your patient if they sounded the same or if there was a difference?
You could, yeah, whether it's
So-
louder on one side or louder on the other. You're kind of getting into the weeds there because, again, this is just a gross test to see if they're hearing or not. But yeah, you could say hearing appears better on the right versus the left. Usually they can tell you that too. Okay, so Weber and Renee only have indicated, let's skip that for right now and come back to it. Don't let me forget it though. So inspect the external ear. So could you move your hair behind your ear? And I'm just going to be inspecting and feeling your ear. So I'm inspecting the lobule. I'm palpating the tragus to see if there's any tenderness. I don't see any masses or any abnormalities in the external or the internal ear. So then you would take your otoscope with your speculum and you would evaluate the ear. And so whenever you evaluate an ear, in an adult you tend to pull up and back and then look. In a child it's better to pull down and back. If that doesn't work, adjust the way that you pull, but this straightens out the ear canal so that you can see. With the internal ear exam, Dr. Morris and I have a joke that there's a couple of ways that you could hold the otoscope. I tend to go with the princess hold with the pinky up because for me, I put my pinky on my patient's face and I look inside, and then that way if they move towards me, my whole hand moves. If they move away from me, that's fine, but that way if you've got a wiggly kid and they jerk all of a sudden, your arm moves with them and you don't poke them in the ear. Versus Dr. Morris's caveman approach, which she says this is how she looks, and she just looks in here and holds it like that. Whatever way works for you is perfectly fine. So when you look in the ear, you say, I'm observing the external auditory canal, and I'm looking in, and I see a light reflex. I see a clear tympanic membrane. I visualize the umbo, and the canal looks normal. So that's your ear exam, and then you repeat it on the opposite side. For the nose exam, you evaluate the external nose. You evaluate to see if there's any signs of trauma or masses. That's fine, and then you evaluate for patency. So how you do that? I'm sorry, I'm late. How you do that is you have your patient occlude one side and sniff, and then occlude the other side and sniff. Now, if you're really focusing in on a neuro exam, which you guys will learn next semester, you will also have them smell something like coffee to see if they can actually determine what the scent is, but we won't have to worry about that right now. And so then what we're going to do is inspect the septum, the nasal mucosa, and the turbinates. You can usually only see the inferior turbinate and maybe the middle turbinate. You cannot see the superior turbinate. But what you do is you have your patient lean your head back and then take your finger and pull your nose up just a little bit. Okay, and so I'm evaluating Gladys's. Now, you can see kind of up close here, Gladys has a normal exam. She has a normal midline septum, because I can see equally both ways. And I can see she has normal mucosa. Now, what you can do, it's a little uncomfortable for your patient, but is you take a different speculum. Please change the speculum so you don't have earwax in your nose. People get grossed out by things like that. Is you insert the speculum a little ways, and I say this may make your nose a little bit itchy. And I look inside to see, and I can see your inferior turbinate on here and in here. And I don't see any polyps, but don't stick it too very far because you make your patient sneeze. And it gets uncomfortable. So that's the evaluation of the nasal mucosa. So now I need to palpate and percuss her sinuses. So I'm going to take my fingers and I'm going to tap on your forehead and I'm going to tap underneath your eyes and let me know if that's tender to you at all. So palpate and percuss that way. Any tenderness? No. Okay. That's the frontal sinuses and the maxillary sinuses. We're going to skip the skin exam since we did that. Now this is the lymph node groups, which we saw some yesterday in class, but we'll go over it again. So I'm going to take my fingers and I'm going to palpate all the lymph nodes that are located in front of your ear, behind your ear, and down your neck. So I'm going to palpate right in front of your ear, behind your ear, and as you're being tested, you're going to say preauricular, postauricular, submandibular, submental. Stick out your tongue. Okay. Anterior cervical, posterior cervical, and superior, supraclavicular. And shrug up your shoulders for me. And that's it.
What does that do when you ask them to stick their tongue out when you're doing submandibular?
If you'll feel, when you feel in your patient, it makes it hollow out a little bit more, and it can force some nodes forward. Whenever you stick your tongue out, it can force some nodes forward that might be more
Same thing with shrugging.
deep. Shrugging, yeah, it just
So you
gives you
get
better
deeper.
access, deeper access. Okay, so that is that. All right, so mouth and throat. So whenever you're inspecting the mouth and throat, this is a lot of inspection that you have to say. So first of all, I'm inspecting my patient's mouth. I don't see any abnormalities, no dryness, no lesions. Can you smile for me? And I'm inspecting my patient's teeth and gums, which look healthy and normal. And open up and say, ah. Okay, so I saw her palate rise, her uvula is midline, her oral mucosa is pink and moist. And her tonsils appear normal bilaterally. Her teeth, her dentition appears normal. Raise your tongue. Okay, and her frenulum is intact. Okay, so that is the mouth exam there. Now, we're going to get a little, yes?
What is the point of saying ah?
That actually tests cranial nerve 12 with the palate rise. So you'll see that. You also can gag your patient, which tests that nerve too to see if there's a gag reflex. And so when you guys do the cranial nerve, you'll be doing that. But you want, whenever your patient says you want to see their palate rise and you want to see their uvula rise. Okay, so now it doesn't say this on here, but I'm going to teach you guys how to do it. We won't test you because we don't make you do it. Normally, okay. Gladys, do you mind me sticking my hand in your mouth?
No.
Hi. So, you sure?
Yep.
Okay. We're demonstrating the HENT exam, Mr. Ward. Okay, so if you're going to do a good dental mouth and tongue exam, you're going to need a couple of things. Is there a tongue depressor over there?
I think there's some behind Kayla.
Oh, are there? Oh, got them here. Okay, so you're going to need a tongue depressor, and you're going to need gloved hands. So, what you do, have your patient stick out your tongue. All right, so I'm going to take my tongue depressor, and I'm going to look on the side of her tongue. And then you take your finger and you glide it down the tongue to feel for any masses. And the other side, take your tongue depressor, and then you glide your finger down your tongue that way. Now take your tongue out, okay, and then look here, and you'll look towards the back, and lift your tongue to the roof of your mouth, and you look underneath as well. So that's a good tongue and mouth exam. Now, whenever you guys are doing this for testing purposes, you're just commenting on their dentition and you're having them stick out their tongue. You're not doing all that, but just so you know how to do it in case you need to. Now, for the neck exam, on the neck exam, you inspect again. You say, I'm inspecting the neck for symmetry, any masses. And so when you're looking at this, you're just looking to make sure that everything looks symmetrical. You're observing the patient's trachea to make sure that it's midline. You really only worry about a deviated trachea for things like trauma or masses, but you're obsessing to make sure that their trachea is midline. We said masses, and then we had to palpate the thyroid gland. I told you guys yesterday in the lecture, and you can look at your PowerPoint, there's a couple of ways to do that. There's the anterior approach, where you locate the cricoid cartilage, which hers is about here, and so the thyroid is immediately surrounding. And so you take your fingers and you have your patient swallow, if she can, or get them some water, and you'll feel the thyroid move up and down. Now, for the posterior approach, you would say to your patient, I'm going to place my hands on your neck. So, again, you locate the isthmus, cricoid cartilage. And to me, I like this approach better because I feel like I get more surface area, and you have your patient swallow. And you'll feel your thyroid move up and down. Now, technically, if it's enlarged on one side or the other, you'll be able to tell by comparing when you're palpating. If there's any masses, you should be able to feel them whenever the thyroid kind of slips up and down between your fingers. So, we're getting a little bit into vascular here, but because it's in the neck, on this list, we talk about the auscultating the carotid artery and palpating the carotid artery. So, what you'll do is you'll just palpate the carotid artery. Hers here. Remember to do that one at a time. You don't want to include both carotid arteries because your patient might pass out. And then when you auscultate, this is a little trick that I learned because I had my ears blown out several times by patients. So if you're listening to the carotid artery, you've got your stethoscope right here, and it seems like every time I would do that, the patient would go, yeah, so, and it would blow me out. So what I do is I have them take a breath and hold it, and then I'll listen to their carotid artery. That keeps them from talking, plus it decreases air noises. Okay, you can breathe, and then I'll have them take a deep breath and hold it on the other side too. So that's just a little, you don't have to do it, but a little tip, so you don't get blown out. Okay, so that's the entire exam. At the end, you had a completely normal physical exam, so I'm going to go let Dr. Morris know, and then thank you for coming in for a physical exam. It was nice meeting you. Do you have any questions?
No.
So that's how you conclude your exam. Took me about, I don't know how long. How long's the video?
13, 15, plus the other one was like 3, so
Okay. About
15.
15, 16 minutes, somewhere around in there?
with explanations, so
With
probably
explanations.
8 with just doing it.
Yeah. So whenever we are testing you guys, we're probably going to want it to be about 15 minutes or less. So work on your time. That as well. Do you guys have any questions right now? Oh, Weber Renee. Whoopsie. Yes.
You said when we do offshoots, is it on like faculty, patients, or people that come from outside? I can't remember who was doing it.
Usually you test on each other.
Okay.
If we decide to get particularly evil, then we'll have other people that you don't know come in. And it may be other students. Usually we're nice and let you test on each other. So, tuning fork. Okay, so Weber and Renee is always done on using the 512 tuning fork, which is the smaller one. So, a couple of things. Remember, we're testing for conductive hearing loss or sensorineural hearing loss. So, things to remember with this is that whenever you remember how to hold your tuning fork, hold it at the bottom, and you can either flick it, tap your knee, tap a surface, something like that to get it to ring. With the Renee test, typically that tests your conductive hearing loss. And remember what I said, conductive hearing loss is usually some sort of outer ear, something blocking the ear canal. Let's draw on the board real quick. Okay, so,
I've got one. Do you want one? I've got one.
yeah, loss.
Okay.
If you have a nice evil, if you have an evil proctor, they'll say, well, show me how you do that and tell me what it means. So that may happen, or they may be nice or in a rush and do it. So let's really dumb down hearing, okay? So here's your ears, that's your head. This little tube is your eustachian tube. Your eustachian tube, and we'll draw a triangle for the hammer, the stapes, and then that's your cochlea, right? Okay, so with the Weber, that tests conductive hearing. So conductive hearing is what's coming out of here and in towards here. If there's a bead or earwax in here, this whole system is going to be blocked. For Renee, air conduction should be longer than bone conduction or louder. There's a couple of different ways to do that. longer or louder than bone conduction. So remember, air conduction more than bone conduction for the Rene test. Now, one way to remember that what Rene is, remember Rene, you put it underneath the pinna or the pinna. Rene under the pinna. So that goes here. So what you do is you either tell your patient, like we talked about in class yesterday, you'll strike it, you'll put it on for bone conduction, usually the mastoid or any bony process under their ear, and you'll say, tell me when you stop hearing it. When they say they stop hearing it, then you put it to their ear. Make sure you always put it perpendicular and not facing them like that, perpendicular, and tell me when you stop hearing it. So the air should be longer than the bone. Another way to do it, which saves a little bit of time, is which one is louder. So you'll strike it, you say, I'm gonna put this behind your ear and I'm gonna put it in front of your ear, and you tell me which one is louder. So you put it on the bone of their ear, let them listen for a few seconds, and then you put it in front of their ear. This should be louder than the bony conduction if the Rene is normal. If it's abnormal, then there's some sort of conductive hearing loss. Take a look in their ear and see if there's a bead in there. Now, for the bone conduction, what happens is when you do this and you place it on a bone, it bypasses the whole conductive hearing and in fact transmits the sound from the bones directly to the cochlea. So that tests sensorineural hearing loss. And that's how that works. There or there. And it bypasses this sound with the Weber, just goes straight there. Now, for Weber, how I remember that, Weber tells you Weber, the ear is better. Okay? So, when Weber lateralizes to the good ear, Weber tells you Weber, the ear is better. So, if it lateralizes to your right ear, Weber, your ear is better. You can hear better over here. That means the sensorineural loss is occurring in the opposite ear. Okay? Because the bony conduction works here, you can hear it better, and it doesn't work there. Does that make sense?
So your patient should tell you that it's equal.
Normal for the Weber is you say to your patient, I'm going to strike this, I'm going to place it on your bone. You tell me whether you hear it better in your right ear, your left ear, or in the middle. And they should say in the middle or both ears or something like that. Okay, so stupid mnemonics and stupid tests. And I'm going to do the louder version just to save time. So, okay, so I'm going to place this on a bone behind your ear, and you tell me for a few seconds whether you hear it better when it's on the bone or whether you hear it better when it's in front of your ear.
Okay.
And just before we do this, you don't have any hearing problems, actually, do you?
I kind of do a little bit.
Okay, well, then you might be a bad patient. Or you might be a good patient. We might see some issues here. So you may want to actually ask yourself, or your patient, before you do this, if there's any hearing problems, or they may have already complained about it. So I'm going to strike this, and I'm going to Rene under the pinna.
Oh, that's definitely louder.
Okay, so her air conduction is more than bone conduction, and you would repeat it on the opposite side. So then to do the Weber test, I'm going to strike this again, and I'm going to place it on the top of your head. Remember, you can place it on top of your head, or you can place it on a prominent area of their forehead, whichever one you want to do. You can make you a fancy unicorn if I wanted to, but I'll just put it up here. And you tell me whether you hear it better in the right ear, the left ear, or in the middle.
Both?
Okay.
I should say middle, but it's more on the left.
More on the left. Okay, so Weber, it's better in the left ear, so you may have some sensorineural hearing loss in your right ear. Now, would I give my patient a diagnosis based on a Weber or Rene test? Absolutely not. But what I would do is I would send you for hearing testing, like formal hearing testing. And that's what those two test by you.
Yay.
Yay. Any questions? Okay, what time is it?
9:15.
9:15. Okay, we got about 30 minutes. So practice, go around, run. You don't have to run